Okay. So if I may, I'm start.
Yeah, please go ahead.
Thank you. So the topic I want to talk about today is about atrial fibrillation. So as we all know, atrial fibrillation is the most common cardiac arrhythmia, and it affects more than 6 million people in Europe only, which shows that this is a problem in an epidemic scale. So what are the options that we have for the treatment of atrial fibrillations and converting patients in atrial fibrillation into the sinus rhythm? So we have two options so far. It's pharmaceutical therapies and also catheter ablations. Unfortunately, as it has been shown in several studies, pharmaceutical therapies has a very limited efficacy. And more importantly, this efficacy of pharmaceutical therapies drops significantly if we have a patient in a later stage of atrial fibrillation, which is an indication showing that the structural remodeling has a significant effect on the efficacy of antiarrhythmic drugs. And more importantly, the antiarrhythmic drugs we have nowadays has a potential to be pro-arrhythmic for ventricles. Due to the modification of the ion channels, which also exist in the ventricles, we can change the conduction properties in the ventricles, which can lead to an arrhythmia, ventricular arrhythmias, which is more dangerous than atrial fibrillation for itself. And that's the reason that nowadays lots of attention has been drawn towards using the antiarrhythmic drugs, which only touches the currents which only available in the atrial, and they do not modify the dynamic of the currents available in the ventricles. So if the patient does not respond to antiarrhythmic drugs, we put the patient on catheter ablation. How well is catheter ablation is that if you look at this graph, we can realize that more than 50% of the patients comes back to the hospital with the recurrence of atrial fibrillation, despite the fact they have been treated initially with the most sophisticated devices we have nowadays. So if you look at it, that we see that even catheter ablation does not do a very, very satisfying job. And all we have now is that the success rate for the AF treatments is far from satisfactory. Recently, it has been shown by Deutschhofer et al. That if you combine these two methods together, you can come with a better efficacy. And as you can see here in this graph, Deutschhofer et al. Showed that if you continue ineffective pharmaceutical interventions, after pulmonary vein isolation, you can get a much better efficacy compared to doing isolated of each other. So here it shows that if you continue on treatment drugs 1 year after the ablations on the patients, then you come with a 20% higher efficacy compared to the pulmonary vein isolation only. However, the mechanism underlying this increasing the efficacy, and what happens that the synergy between the pharmaceutical interventions and catheter ablations comes into the play that increase the efficacy of the treatment is still unknown. So here comes a hypothesis. So here in this study, we try to test whether the inward rectifier currents blockade, which from now on, I will call it IK block, which is more or less mimicking what we have as atrial selective currents, can reduce AF inducibility in the simulations. And if yes, what is the mechanism underlying this that's showing this synergy? And we can understand the underlying mechanism for the increase in the efficacy of this treatment option. So here is the model, as you can see in the slide. So the model is from the human atria. The global geometry of the model is from the MRI, but the key anatomical features like the heterogeneity in the atrial wall thickness, endocardial bundles, and left atrial appendage and trabeculated network, which has been shown in several studies that play an important role in the AF initiation, is added manually to the model based on the several anatomical studies. And also the model has 3 layers of fiber orientations, and the fiber orientations and intra-atrial connections, and also the connection from the coronary sinus, which all has been driven from the anatomical studies has been done so far. And structural remodeling has been modeled by fibrosis. So here in this model, we incorporate fibrotic elements into the model. As you can see it here in this slide, this has been depicted by the white material. And the fibrosis was simulated by removing the transverse conductivities and untouching the longitudinal conductivities. And this is more or less illustrated. The work has been done by Spach et al. In 1980s, and also the bundles is remain untouched. So there is no fibrosis introduced in the bundles, and fibrosis is mainly introduced in the epicardial tissue, and this is based on the study by the Verheulen et al. That he showed that fibrosis mainly occurs in the thin epicardial layer. And on the bottom, you see the way that we simulated the pulmonary vein isolation. So the pulmonary vein isolation was simulated by using inactive tissue in the lesion area, as depicted here by the white dashed line. And the black star shows the pacing points. So here we have more than about 20 pacing points, which has been uniformly distributed between both atria. And the pacing protocol is incremental pacing. So it's a pacing with a reduction in the cycle length. And we continue the pacing for 2 seconds. And then if after 2 seconds, any kind of activity has been initiated, we consider this as successful. And if the pattern becomes like a flutter, then we consider it as a termination, so a successful prevention in AF initiation. So here is an example. So here we have the simulation with the pharmaceutical intervention. So we start pacing from the coronary sinus. And as you can see, even with a little amount of fibrosis, with a 50%, so now we are in a moderate scenario of the structural remodeling, you can successfully initiate atrial fibrillation in this patient. So this is what we have seen so far in the publications, that if the patient has a higher structural remodeling, the antiarrhythmic drug efficacy drops. What happened with the pulmonary vein isolation? So here you see an example of the simulation with the pulmonary vein isolation and with the 70% fibrosis. So as you can see here, the severe amount of structural remodeling makes play an important role in a way that it can initiate AF even after the pulmonary vein isolation. And here you have an example of the combination of these two in the presence of the severe amount of fibrosis. So here in this simulation, in this movie, I just kept it in slow motion that you can appreciate the dynamics behind it, and you can see how the waves are big, and the modification of the substrate are such a way that do not let the fibrillation wave to survive. So let's have a global view. So here in this graph, you see the control simulations, and by control simulations, we mean no RK block, no PVI. And if you take a close look at this graph, you can see that with the increasing amount of fibrosis depicted in the x-axis here, the chances that you can initiate atrial tachycardia is higher. And the black solid color shows the AF, atrial fibrillations, and the striped color shows the flutter, and the flutter considered as a success in AF prevention, AF initiation prevention. So increased amount of fibrosis significantly increase the chance that you can initiate atrial fibrillations in the simulation. What happens if you add the antiarrhythmic drugs? So here we add IK block with 30% block IK1 here. And as depicted here on the graph on the bottom right, you see the prolongation of action potential durations in the presence of the IK block, and it's about a 20% increase in action potential duration, which is reported in several experimental studies. And on the top, you see the conduction patterns in the presence of the antiarrhythmic drugs. And what you can see on the graph on the left is that the antiarrhythmic drug can significantly reduce AF initiation prevention and AF initiation rate only in simulations without fibrosis. And as soon as you start having fibrosis, like a moderate fibrosis as like 50% fibrosis and severe fibrosis as like a 70% fibrosis, the efficacy of antiarrhythmic drugs drops and it could not prevent AF initiation. So what happens if you have PVI only? So the PVI only depicted here in the red column. And you can see that PVI, like antiarrhythmic drugs, is effective only in the simulations without fibrosis. And here in this scenario, in the simulation with moderate fibrosis. So PVI is effective significantly to prevent AF initiation only in the simulation in which you have a moderate or without fibrosis. And as soon as you have a severe amount of fibrosis, which can represent patients in persistent atrial fibrillation, then the efficacy of this treatment option drops. And what happens if we combine them? Here is a green column that you see that the efficacy of the combination of these two treatment options and the synergy produced by the combination of these two could significantly reduce AF initiations in all scenarios with the fibrosis. Without fibrosis, moderate or severe fibrosis, it's going to work. So it could significantly reduce the effect of the AF initiation rate. But what's the mechanism underlying this? So we went further to look at the mechanism underlying this synergy between these two treatment options. So one of the parameters that we could look is the number of waves, fibrillation waves that we see in the simulation. So it's a parameter which can show the complexity of the conduction patterns. And if you look at this graph, you see that the presence of the IK block in the simulation without fibrosis significantly reduced the number of waves. So it's reduced the complexity in the conduction patterns. And that's the same scenario with the PVI. And even more strongly, you can see this if you have a PVI from IK blocker. And this is the same scenario. If you have a moderate fibrosis, only PVI could reduce the complexity and the PVI plus the IK block. And in the severe fibrosis, only the PVI plus the IK block could significantly reduce the complexity in the conduction pattern. And which is very interesting. So what happens if we see this phenomenon is that we started looking at the wave generation rate. So the wave generation rate is the rates that you see a newborn wave as a result of a wave break or as a result of the transmural conductions or the breakthroughs. So the wave generation rate is simply the slope of the red lines you see in the 4 graphs in the bottom of this slide. And these 4 graphs shows that when a wave is born and how long the wave survives. So x-axis shows the time, and the y-axis shows the wave ID. So if a new wave is born, then it gets a new ID. And then we track this wave over time and space, and then we see when the wave is terminated or is extinguished from the simulation. So if you look at it here, you see that IK block could reduce the wave generation rate only in the simulation without fibrosis. And PVI is without and moderate. And again, the same scenario, PVI plus IK block could significantly reduce the wave generation rate. And why is that? That's simply, if we look at the excitable gap available, or here I just use another parameter, which is a wave size per cycle, you see that the substrate modification caused by the pulmonary vein isolation and the prolongation of the wavelengths caused by the IK1 block, these two could lead to the point that there's no space available for the other waves to survive, and there's no space available for the new wave to born. And this reduced the complexity of the conduction patterns, which in the end, it turns to the termination of the fibrillation patterns. So we could realize that what's the mechanism underlying that we see this increase in the efficacy when you combine these two methods together. So to conclude that, I showed that antiarrhythmic drugs could significantly reduce AF recurrences only in the atria with a low degree of fibrosis. Pulmonary vein isolations could reduce AF initiation in the simulation with a low and moderate fibrosis, but the combination of these two has a synergic effect by changing the reduction of the excitable gap available, increasing in the wave size, and also the substrate modification caused by the pulmonary vein isolation, which lead to the reduction in the AF initiation rates, even in the atria with the severe structural remodeling. And by this, I would like to thank you, and I'm ready for the questions. I'm happy to take them.
Thank you very much, Ali, for your presentation.
Thank you.
I'm asking the audience if there is any question. Actually, I was curious about the three-dimensional electrophysiological model. Perhaps you mentioned it, but I might have lost it, missed it. How did you get the fiber orientation?
So the fiber orientation is coming from the anatomical studies. So it's from the study by the Ho et al. So we looked at it and we just simply took the fiber orientations from the presented slides in the anatomical studies that they.
Okay.
Yeah.
Okay, there's a question. There's a raised hand by Francisco Sali.
Hi, Ali. Nice presentation.
Hello. Thank you.
So I have a question. And so when you do the statistical comparison between the different cases, so did you like run the model multiple times? Because what I understood is that you run multiple sites and see if you can induce AF or not, right?
Yes, that's correct.
But that will just give you one proportion, right? So how do you compare statistically between the two cases?
So in all cases, the pacing points are the same. So we don't change the pacing points, and the pacing protocol is also the same. So we only do like 20 different simulations, and among them, we just extract the ones which AF was initiated, and then we just simply did the one-way ANOVA test to see whether they are statistically different or not.
Okay. Okay. Yeah. Now I understand. Thanks.
Okay, other questions? Okay, good. So we thank again for this presentation.
Thank you.